Thank you, Mr. Speaker. Good afternoon. Sorry for the delay. Really, I get my presentation and my phone laptop for charging for lunch, but something expected. I am Dr. Ahmed. I'm going to speak about the dilemma of implantation in prelingual different adult in Egypt. Prelingual different adult were considered poor candidate for implantation. They are advised to learn the sign language. In Egypt, there is no adequate number of deaf schools. There is no facility to get benefit from the sign language, even if it's learned. The problem is more pressing because there is a lack of new data screening program, so the number of this patient tends to be increasing. If this is regarded as a social stigma here, versus being regarded as a group in the developing country, these patients are not covered by public medical insurance. There is no re-employment program to help the deaf finding a proper job even after implanted. Patient becomes social and financial burden. And so there was a very nice movie in the opening ceremony about it. Prelingual deafness can be defined as severe profound hearing loss with its onset before the development of language. This was clear what's meant by before. He said before the development of the clearest language, and in this case, only patient having profound deafness by the age of 2 to 3 years will be included. Or it is before the development of the full language. And in these cases, patient having profound hearing loss by the age of 3 to 6 years will be included. Also, there is uncertainty regarding the degree and the course of the deafness. Should only patient having profound deafness from the start be included, or can patient having moderate or severe hearing loss progressive profound deafness be included in this group? So really, in fact, this group of patients is heterogeneous. And the performance of this patient after cochlear implantation is highly variable because of the heterogeneous nature of the hearing loss. It's unclear which subgroup of this patient would benefit from delayed cochlear implantation. For sure, little benefit will be expected from those who have been totally deaf by the age of 2 years. And some benefit can be anticipated from those who have had a small amount of auditory stimulation due to residual hearing before progressing to profound deafness. And for those who developed some speech in the early childhood, but because of the lack of deprivation and the lack of the feedback mechanism on the auditory speech, their early speech become unintelligible at the time of cochlear implantation. Cochlear implantation can be measured objectively by speech discrimination test and subjectively by quality of life test measures. Also, quality of life measures correlate well with the speech discrimination measures in post-lingual and deafness and in prelingual children. This correlation is very poor in prelingual deaf adults. Prelingual deaf adult may show some improvement in speech discrimination scores, which is highly variable and limited when compared to the traditional CI recipients. So they are tend to continue to sign or read as their main means of communication. According to quality of life measures, the benefits for these patients were more outstanding. They have better sound awareness, better everyday, overall communication ability, better speech understanding, better opportunity for employment, and there was improvement in cognition, emotional well-being, and self-esteem and social interaction. To conclude, the social factors in Egypt, the heterogeneous nature of the hearing loss, the improvement of the quality of life outcome measurement noted in these patients, and the recent evidence of the better than expected speech discrimination score in these patients, and the recent evidence of other brain plasticity. All these factors should drive us to adopt a more relaxed criteria for selecting prelingual deaf adult for cochlear implantation. To facilitate this, the adult profound prelingually deaf implant profile form was suggested by Dr. as a guide. It is based mainly on the duration of the auditory deprivation, usually has to be less than 15 or 20 years. The speech intelligibility rating scale better than 1. Speech perception level has to be better than 1. And mode of communication has to be mainly oral mode. This is the form. This perception. So far, we implanted for patients inclusion criteria all the age range between 10 to 15 years. Post-operatively, all have discrimination scores ranging from 0 to 35. All have dramatic improvement in quality of life when compared to the pre-implanted status, and they were able to live as their own. This is this video shows Prelingual young adolescent implanted at the age of 12 years. He has been refused several times. He has been refused several times by medical insurance to be implanted. The first video before rehabilitation, immediately after implantation.
اسمك ايه؟ اسمك ايه؟ أحمد آدم؟ أحمد خالد يعني أحمد خالد أنت بتروح المدرسة؟ بتروح المدرسة؟ اسمها إيه المدرسة؟ اسمها إيه المدرسة؟ اسمها إيه المدرسة؟ عندك إخوات؟ عندك إخوات؟ عندك إخوات؟ في عندك إخوات؟ عندك كم سنة؟ عندك كم سنة؟ عمرك كم سنة؟ طب كلمة أنت تعمل إيه جنبك؟ تعال امسك جنبك. هو ايه الكلمات اللي بيقولها؟
This is 1 year after open implantation, about 9 months after here. He has some sort of speech stimulation. Can you
أرنب كلب عربية طيارة نظارة قطر مروحة على صوت مروحة تلفزيون عجلة كمبيوتر مدرسة
This patient should be implanted as early as possible, preferably when they are young adolescents. Thank you so much.
Thank you very much, Professor Shami. Any questions? Yes, please.
Thank you very much. That was very interesting communication. I was wondering whether you have a forum or a group of similar children or adolescents where they can meet together and whether they can exchange their experience they had with their cochlear implants to make expectations of the parents and of the adolescents not too high to prevent from disappointing.
And you just get the point.
No. Yeah. Should I go closer? Is that better? I was wondering whether you have a group of similar patients where they can meet before the decision is made and they can exchange experience they had when they their cochlear implant, and when parents, this is something I think very, very important to keep the expectations low, to prevent from disappointment.
Really, I totally agree with you, but our number is so limited, and these patients are from distant area away from us. This patient from Kenya is about 500 kilometers from Tanta, my place, you know. So, but I agree, it's a good idea.
And it would make sense. I mean, nowadays we have all these chat forums, and they can chat and, do over internet. They can meet each other over the internet without being physically there, but they can sort of interact with each other. And that would be an important improvement. I think this is a very interesting idea, and I support the idea very much. But I think it's also important to have these parents meet other parents, exchange knowledge and expectations to make them, to prevent from being disappointed. As you pointed out, the result is not compared to other cochlear implantees. It compares very low benefit. But I agree with you. I think this is an important aspect to give these youngsters some hearing and some kind of a future. Nevertheless, I think it's really important to have them meet each other, at least, maybe not physically, but at least on the internet forums or something like that.
I totally agree with you. So support is very important in the rehab process of this patient as well.
Right. I find the support in our setting, I mean, I'm from Switzerland, so the distances are really small, there's 5 centers and 8 million people. So we can manage to get next door somebody who has similar conditions. But I find myself, it's facilitating my work, and it's an additional aspect in counseling. If they can meet other people, talk to other parents who have similar experience, maybe the youngsters can also interact with other people wearing cochlear implants.
Likewise.
Yeah.